All right, so we have hip fracture case number one here. I'm Ryan Will from Olympia, Washington. I've got a big chunk of my practice is kind of dealing with geriatric fractures at a level 3 center, so I kind of have that kind of bent on this. So first patient is a 63-year-old female who she works in one of the surrounding communities as a triage nurse at an outlying family practice office. She unfortunately was at work and slipped and fell and landed on her right hip. And after that, just couldn't bear weight on the right side, but didn't have any obvious shortening of her leg. Baseline, she enjoys an active lifestyle, doesn't require any ambulatory aids, and doesn't have any outstanding health issues and no previous fractures. And presented to our emergency department with these X-rays, and tried to kind of keep this sort of in ortho bullets format, so everyone can see those, I think. So I guess the next would be, how do we classify this fracture? So kind of generated a long list. So is this a varus displaced neck fracture, non-displaced, a valgus impacted? Would you classify it by using the AO scheme or the Garden classification scheme? My preference is to kind of call it either displaced or non-displaced, and if it's or valgus impacted. And so I thought this was a valgus impacted fracture and discussed that with the patient. Kind of keeping with the question number two would be, how would we treat this injury? So reduce versus fix, with the idea here being of, do you reduce this to perfect alignment, or do you try to stabilize it so that it's still useful for the patient and they can still have a good outcome? And so so you could choose non-operative treatment. We're here at an orthopedic surgery conference, so probably not going to be that. Closed reduction with cannulated screws, or closed reduction with femoral neck system from Synthes, or any similar kind of device that are out there by a number of different manufacturers. I just didn't have a generic name for it. Closed reduction with a sliding hip screw, with or without a derotational screw. Do you vote for open reduction with the internal fixation? And then some arthroplasty options. So kind of discussion, taking this from off of Feels Good Talk here. So goals of care. What does the patient want? Does she want something that's going to restrict her weight bearing potentially? Does she rather have something that's going to allow her to bear weight as rapidly as possible? How can she get back to work? She is still working full time. How can we minimize her complications, particularly now in a time of COVID, when coming back into the hospital is really hard? People have to get screened, and for God forbid they have to come from a congregational care center, which I didn't know that was a term, but now it is, that we all know. It's really hard. So how can we sort of minimize these risks, and how do we discuss them with the patient? All have a significant impact. My goal is to try to get her weight bearing as soon as possible. We talked about arthroplasty versus repair, and that her desires that she wanted to avoid arthroplasty. She wanted to get back to work as soon as possible, and she had a vacation to Arizona about a month later that she was not going to miss. So what we decided on was doing a closed reduction with the femoral neck system. And this isn't an advertisement, I just don't know what else to call it. Device that works with a big peg basically, and a derotational screw to help support the femoral neck and keep it in a good position. In my mind, I think about this in cases where I would maybe do cannulated screws. I think this is kind of replace cannulated screws in my toolkit now. I don't do too many of cannulated screw cases anymore, but I think that for this patient, this was a reasonable option. On her post-operative course, she was able to bear weight immediately, and she actually went home on post-op day 1 feeling much better. At her first post-op visit about 2 weeks later, she came in using a cane only and asking when can I go back to work. This was in February, late January, early February of 2020. So when she was going to come back for her next post-op visit, obviously we had all medical care shut down in Washington State. So she had a little delay in getting back, but she was able to get back to work by her second visit. And despite this being an L&I claim, she was able to close it within 5 to 6 months, even despite COVID, and she was really pleased with the outcome. And these are her final radiographs about 7 months or so after surgery. With some remodeling, but stability of the fracture hasn't really shortened very much, and I think that contributes to her outcome. Chuck, should we kind of talk about anything else or any other? I can't quite see on my screen here any questions or things that we can address from the audience. Or
I don't think anything's shown up in the Q&A, so I think we can move on to the second case.
Can I say one
Actually,
thing?
you know, oh yeah, yeah. Go ahead, James.
Oh, on the lateral view, one of the only real problem that they've identified with this device is if that cortical screw, which actually it's a locking screw, but the transverse screw, the inferior one, if it's a little bit too eccentric, it acts unicortically and can create a stress riser. It looks like you're bicortical, but you're riding right inside the anterior cortex. So if anyone's using this device, the technique, they recommend really making sure that that locking screw that's transverse, the most inferior one, is really carefully bicortical, so it doesn't create a stress riser. But I think that's a beautiful demonstration of a locked femoral neck plating system with sort of a minimally invasive insertion.
While they're switching, Chuck, there's one other thing I'm going to say. I do a fair number of the FNS as well. There's a couple of things that I've found that I think helps mitigate that risk that James was talking about. I always use a 2-hole plate, and I use the shortest screw available in the distal most hole. So it's kind of a unicortical taper to prevent some of that potential toggle if I'm off a little bit. And then the other thing is I take the barrel almost up to subchondral bone. I try to get it as deep as I can. And you can almost make the derotation. You can almost always take the derotational screw 5, sometimes 10 millimeters longer than the barrel. And I think that really helps with rotational stability.
And that being said, this was the first time I had used the system, so I was pushing the envelope for myself at that time. And the guide just feels, it's a little, if you're used to using a old DHS handle and you have that kind of feel and muscle memory, the FNS and other similar systems, they kind of change the handle to kind of match, but it doesn't have the same feel. So it's a new kind of feel and touch to kind of feel comfortable where you're putting your pin, which is obviously critical for this to work.